Bismillahirrahmanirrahim. On to the second part. So let's start with the twin pregnancy. So twin pregnancy types are monochorionic, monoamniotic. It means that they have one placenta. Like suppose these are the fetuses. Okay. Yep. So suppose that these are the fetuses like this. Both of the pardon me. Both the fetuses are in one amniotic cavity which is attached to a single placenta like this. So this is monochorionic monoamniotic twins, and it is a state in which the separation between they are coming from a single zygote. The monochorionic monoamniotic twins are formed when zygote undergoes division after 13 days of fertilization. So there is one placenta and one amniotic sac, and there is a chance of cord entanglement. Then we have monochorionic but diamniotic. They are more common in comparison to monochorionic monoamniotic, which are the rarest form of twins. And they have, like, this variety has a chance of development of conjoined twins as well. So monochorionic diamniotic means that the placenta is same, like there's one placenta which is supplying both of them, but both the fetuses are in their separate amniotic sac and they are connected. Like suppose this fetus is like this and connected to this placenta, and there's another connected to this placenta. So this is monochorionic diamniotic twin, and one placenta with two amniotic sacs, and there is a T sign or at intertwin membrane, T sign, or you may say lambda sign, that when we do the ultrasonography, so there is, this is placenta and this is the intermembrane intertwin septum which is thickened, so that makes us a configuration of a T, or maybe you may say it something looks something like a lambda. Then we have dichorionic diamniotic twin. It happens when there are two ovums, two ova get fertilized by two different sperms. So there are, suppose this is the uterus. So this is one placenta, and to this placenta we have attachment of a twin here, and the other twin is attached over here, something like this. So this is, these are they are not supposed to be joined, but this is something that happens in a dichorionic diamniotic twin. I'm sorry, lambda sign is present in the dichorionic diamniotic twin, while the okay. So dichorionic diamniotic, two placentas, two amniotic sacs, and lambda sign is present at intertwin membrane. So they can be together as well. They are not always supposed to be separately attached. They can be like there are two placentas and two amniotic cavities, and between them there will be a lambda sign. There will be a T sign in monochorionic diamniotic twins and a lambda sign in dichorionic diamniotic twins. Twin in anyone sharing same chorion. Okay. Then we have maternal complications. Maternal complications are basically all the complications of pregnancies multiplied by 2, right? There will be just exaggerated complications of normal pregnancy, like there will be hyperemesis gravidarum, there will be preeclampsia, then there will be gestational diabetes mellitus, iron deficiency anemia. The fetal complications are congenital anomalies, fetal growth restriction, preterm delivery, malpresentation, for example, breech, monochorionic twins, twin transfusion syndrome. Monoamniotic twins have a chance of development of conjoined twins and cord entanglement. If there is one placenta that is shared by two fetuses, there is a chance of twin-to-twin transfusion syndrome because of some arteriovenous connections which can form in the placenta. And in case of monoamniotic twins, where both the twins are sharing an amniotic sac, there is a chance of development of conjoined twins or maybe cord entanglement. Then here is a picture showing something like this is the fetus A, this one, and this is the fetus B, and there is a thin intertwin membrane and no intervening chorion. So they are monochorionic diamniotic twins in which there is no intervening chorion. So they are just two twins attached to the same placenta in different amniotic cavities. If I could show you this one, so here you can see that there is a lambda sign in which dichorionic diamniotic twins are present. So these are the twins with two different placenta and two different amniotic sacs. So there's a lambda sign which is formed between them like this. And then we have over here this picture. This picture. So this picture is showing again lambda sign in this picture. So here again is a lambda sign like this. Like there's a lambda sign, and here we have the T sign in the next picture. T sign is about the is present in the monochorionic diamniotic twins, right? So this is T sign. T sign is present in monochorionic diamniotic twins. Monochorionic diamniotic twins have T sign. Okay, got it. Then we have monochorionic monoamniotic twin risks. So firstly, there is the chance of preterm birth, common to all types of twin gestations. Due to uterine crowding and uterine overdistension, increased prostaglandin production that will lead to increased oxytocin receptors and increased contractility of the uterus. It can also be induced because of increase in maternal, for example, preeclampsia, and fetal, like fetal growth restriction, discordant growth complications. So it can be induced by maternal or fetal complications as well. Single placental risks are twin to twin transfusion syndrome, single amniotic. So if there are, even if they're diamniotic but monochorionic pregnancies have a chance of twin to twin transfusion syndrome. Single amniotic risks are umbilical cord entanglement and intrauterine fetal demise. Management, inpatient management starting at 28th week of gestation, frequent fetal monitoring, antenatal corticosteroid administration, and delivery at 32 to 34 weeks, that is preterm, by C-section. Monochorionic monoamniotic twin cord entanglement can occur like this, like the cord of both fetuses can entangle with each other. So this is single amniotic sac, cord entanglement is happening over here, and single shared placenta, as you can see. Then we have various types of twin placenta. These are monochorionic monoamniotic, like in which we have two umbilical cords attached to the same placenta of the fetuses which are present in the same amniotic cavity, right? So this is placenta. The outer reddish covering is the chorion, then the inner one is amnion, and we have the amniotic fluid. In dichorionic diamniotic twins, in which we have this lambda sign between them, so we have two amniotic sacs like this and this, two placentae, like this is its placenta and it has a different placenta, but they're very close together, that is why it looks like one. Then we have monochorionic diamniotic, in which a single placenta is supplying two fetuses which are present in two different sacs, like this is an amniotic sac, this is an amniotic sac, and these are two different placenta, and they are forming monochorionic diamniotic forms a T sign. And dichorionic diamniotic can also give a picture like this. This is dichorionic diamniotic fused, and separate ones which may be attached at different locations of the uterus, they look something like this. They don't make a lambda sign, they just are two separate fetuses, placenta, chorion, amnion, and amniotic fluid, and you can see that. Next is T sign and lambda sign. T sign signifies one placenta, monochorionic, and two amniotic sacs. Lambda sign signifies two fused placentae, dichorionic, with two amniotic sacs. So here is the T sign, like this one. So in this picture, chorion and amnion, the chorion is single, like this is monochorionic diamniotic twins. So if I could zoom it in, so here you can see that we have this T sign which is formed like this, and there is a single placenta with two amniotic sacs. Here we have a lambda sign in which you can see although the placentae are fused together, but they are two separate placenta, like this one, and they are making this lambda shape appearance. Over here you can see like this lambdoid appearance is making the lambda sign. So if the dichorionic diamniotic twins are separately positioned, that is not much of a hassle. We just know that they are separate, right? The problem is when they are fused, now we have to separate them from monochorionic diamniotic twins. So for that purpose, we look for T sign or lambda sign, and then we differentiate between the two. Then we have the next point. Just give me a second. The next thing is over here. Yeah. So this is dichorionic diamniotic twin gestation with twin peak lambda sign. So again, we have dichorionic diamniotic twin gestation, like with a fused placenta. So they are making this twin peak or lambda sign. Fetus B and fetus A is over here. The next thing is twin transfusion syndrome. Complication in the donor. Now, whenever there is a transfusion syndrome, so there are two twins which have an aberration in the blood connection, and this happens in the twins who share the placenta, like monochorionic twins. So complication in the donor, like suppose this is the donor twin. No, this is not the donor twin. This is the recipient one. The donor twin will be definitely small. Like this is the donor twin, and this is the recipient twin. So there will be discrepancy in the size of both the twins. So in the donor twin, there will be anemia, renal failure, oligohydramnios, low output heart failure, and fetal growth restriction. In the recipient, the opposite will be happening. Like there will be polycythemia, polyhydramnios, cardiomegaly, high output cardiac failure, and hydrops fatalis. Treatment for the mild twin-to-twin transfusion syndrome is serial ultrasound to look for worsening clinical features. Moderate to severe twin-to-twin transfusion syndrome, we can do the laser coagulation of placental anastomosis. So this is the donor twin, which is very weak and frail, and this is the plethoric polycythemic twin, which is the recipient having the polyhydramnios. So inside the placenta, which is a monochorionic situation, single shared placenta, umbilical arteries, single umbilical vein, and AV anastomosis are present. So they are causing this twin-to-twin transfusion syndrome. Then we have hyperemesis gravidarum, which can happen in normal pregnancies and most commonly in the twin pregnancies. So pathophysiology is increased beta HCG and progesterone in pregnancy. We see abnormally high level of beta HCG in molar pregnancies. That is why hyperemesis gravidarum is also present in molar pregnancies as listed here. Increased beta HCG symptom, nausea. Increased progesterone symptom, vomiting. Beautiful. Like nausea is because of beta HCG and vomiting is because of progesterone. Because of relaxation of lower esophageal sphincter, that is gastroesophageal reflux, and stomach, that is delayed gastric emptying. Now progesterone normally causes the relaxation of smooth muscle. When it causes the relaxation of lower esophageal sphincter, the vomiting becomes feasible because the lower esophageal sphincter is not patent. The stomach content can spill into the oral cavity, and out of that will be vomiting, and stomach also becomes lax, like there will be delayed gastric emptying. So even that favors vomiting. Risk factors are poor prior history of hyperemesis gravidarum, multiple. So in OBS and gynae, it's a kind of a buzzword that for any disease, the most important risk factor is a prior history of that particular disease. Then multiple gestation, hydrotatiform mole, history of esophageal reflux, history of migraines or motion sickness. Self-note, it seems that hyperemesis gravidarum is linked with increased beta HCG level, and its risk factors are the same, which are accompanied by increased beta HCG. It resolves by 16 to 20 weeks of gestation but can persist until delivery. It is characterized by dehydration because the woman is losing fluids by vomiting, dry mucous membranes, delayed capillary refill, tachycardia, hypoglycemia, there will be ketonuria, orthostatic hypotension because of dehydration, electrolyte abnormalities, there will be hypokalemic metabolic alkalosis. More than 5% of the loss of pregnancy, weight. Serum chemistry will show hypochloremic metabolic alkalosis, hypokalemia, ketonuria, basis of differentiating it from the normal vomiting, increased serum aminotransferases. It can also be associated with the transient hyperthyroidism, thyrotoxicosis of hyperemesis due to stimulation of thyroid by elevated beta HCG. Again, the same concept. HCG and TSH have a similar alpha chain, so either of them can stimulate the receptors of the other. So if we have increased HCG, it can cause hyperthyroidism, transient. Tobacco use protects against hyperemesis gravidarum. You must remember that tobacco use, although is a teratogenic and has a lot of bad things, but smoking has a protective effect against hyperemesis gravidarum and also preeclampsia because it increases the metabolism of estrogen and decreases serum estrogen. Okay. Hyperemesis gravidarum, the risk factors: hydrotatiform mole, multifetal gestation, history of hyperemesis gravidarum. The clinical features are severe persistent vomiting, more than 5% loss of pregnancy weight, dehydration and orthostatic hypotension. Lab abnormalities include ketonuria, hypochloremic metabolic alkalosis, hypokalemia, hemoconcentration. Treatment is admission to the hospital and antiemetics and intravenous fluids. Then we have Wernicke encephalopathy due to hyperemesis gravidarum. This happens because of thiamine deficiency, and that can be a symptom or side effect of hyperemesis gravidarum as well. And neurological disease due to thiamine vitamin B1 deficiency. Presentation is altered mental status, oculomotor dysfunction, for example, nystagmus, gait ataxia, bilateral absent ankle reflex. It is also called as confusion of thalmoplegia and ataxia. No, it is a triad. Wernicke encephalopathy is a triad of confusion. ophthalmoplegia, and ataxia. Lab finding will show hypochloremic metabolic alkalosis, hypokalemia, hypoglycemia, and increased serum aminotransferases. Treatment is the treatment is antiemetics, fluids, thiamine supplementation, glucose infusion. Glucose infusion prior to thiamine supplementation can exacerbate the disease and should be delayed until the patient has received thiamine. This disease increases the risk of spontaneous abortion. The differentials include acute fatty liver of pregnancy, occurs in third trimester, jaundice is present. Okay, so deliver, what is the meaning of that? Is it a mnemonic or is it an indication? Okay. Wernicke's encephalopathy, the table. So here you can see that associated conditions are chronic alcoholism, which is most common with Wernicke's encephalopathy, then malnutrition, for example, anorexia nervosa, and hyperemesis gravidarum. There is similarity between these two conditions. Both have vomiting as a symptom. So basically, any condition that decreases the vitamin content in your body, either because of lack of intake or because of excessive, vomiting that expels the vitamins out of your body, can cause Wernicke's encephalopathy. Pathophysiology is thiamine deficiency. The clinical features are encephalopathy, oculomotor dysfunction, for example, horizontal nystagmus, bilateral abducens palsy, postural and gait ataxia. Treatment is intravenous thiamine followed by glucose infusion. So, thyroid hormone production during the pregnancy. Thyroid hormone production increases during the pregnancy by following two mechanisms: estrogens and HCG. Estrogen stimulates the synthesis of thyroxine binding globulin and decreases the thyroid binding globulin clearance. This leads to increase in bound thyroid hormone, which in turn leads to increased thyroid hormone production to maintain free hormone level. HCG has a common alpha subunit with TSH and a similar beta unit. Thus, it stimulates the TSH receptor directly to increase the thyroid hormone production. Net effect is subclinical hyperthyroidism with increased total T3 and T4, normal or mildly elevated free T4 and suppressed TSH. Patient remains clinically euthyroid. However, patient with pre-existing hypothyroidism, for example, chronic lymphocytic Hashimoto thyroiditis, cannot increase thyroid hormone production, resulting in a relative hypothyroid state. Hence, such patients with a baseline hypothyroidism who become pregnant should have their replacement thyroxine dose increased. Maternal thyroid testing in pregnancy first trimester. Total T4 will be increased, free T4 unchanged or mildly increased, and TSH will be decreased. Mechanism: beta HCG stimulates thyroid hormone production in first trimester. Estrogen stimulates thyroid binding globulin. Thyroid increases hormone production to maintain steady free T4 levels. TSH will be decreased. Increased beta HCG and thyroid hormone suppresses the TSH secretion. Then we have neonatal thyrotoxicosis. Pathophysiology: transplacental passage of maternal anti-TSH receptor antibodies. Antibodies bind to the infant's TSH receptors and cause excessive thyroid hormone release. The clinical features are warm, moist skin, tachycardia, poor feeding, irritability, and poor weight gain, low birth weight or preterm birth. Diagnosis is maternal anti-TSH receptor antibodies more than 500% of the normal, and treatment is self-resolves within 3 months disappearance of maternal antibody, methimazole plus beta blocker. Sheehan syndrome, pathogenesis, obstetric hemorrhage complication by hypotension, postpartum pituitary infarction. The clinical features are lactation failure, that is decreased prolactin, amenorrhea, hot flashes, vaginal atrophy, decreased FSH and LH, fatigue and bradycardia, that is decreased TSH, anorexia, weight loss and hypotension, that is decreased ACTH, and decreased lean body mass, that is decreased growth hormone. Then migraines. Migraine headache are common during the childbearing age due to cyclical changes in estrogen and progesterone. Okay. Headache improves during pregnancy due to loss of these cyclical changes, but some women have worsening symptoms. So basically, pregnancy cures migraines, right? Migraine headache are common during childbearing age due to cyclical changes of estrogen and progesterone. During pregnancy, this cyclical change stops and there is a steady level of estrogen and progesterone in the body, so that improves symptoms in some women, but for others it causes the worsening of symptoms, likely due to an increase in other migraine risk factors, for example, sleep disturbance, physical exertion, emotional distress that occurs during pregnancy. Treatment is written below in the table. For pregnant patients, the drugs are chosen on fetal safety profile. Preventive medications are beta blocker first line, calcium channel blockers, abortive medications like acetaminophen, add codeine, antiemetics like promethazine or caffeine, butalbital to acetaminophen if monotherapy with acetaminophen does not work, oxycodone if combination therapy does not work. Ergotamine and triptans are contraindicated during pregnancy. Ergotamine and triptan causes hypertonic uterine contraction and vasoconstriction, preterm labor, fetal growth restriction. Prolonged beta blocker use can cause growth restriction due to decreased placental perfusion from low blood pressure. Therefore, patients should be initiated on the lowest effective dose and require frequent monitoring. NSAIDs can only be used in second trimester. Use in other trimesters have following complications. In first trimester, NSAIDs can cause risk of miscarriage. In third trimester, fetal complications because of premature ductus arteriosus closure. You should remember that the ductus arteriosus is the patency of ductus arteriosus is maintained by the PGE2, and if you give NSAIDs, which is an antagonist, kind of an antagonist which inhibits the synthesis of PGE2, so that will cause a premature closure of the ductus arteriosus, which can be fatal for the child. Then oligohydramnios and renal dysfunction. Then we have this gold. Increased risk of estrogen containing OCPs in the females. Increased risk with estrogen containing OCPs in the female. Estrogen leads to increased risk of thrombosis, and this can lead to ischemic stroke. So discontinue a female taking OCPs and has migraine with aura. Discontinue OCPs in a female. Okay, so discontinue the estrogen containing OCPs in a female who has migraines with aura, because in that patient it can lead to ischemic stroke, right? Something like that. Increased risk of estrogen estrogen containing OCPs in the female. Estrogen leads to increased risk of thrombosis, and this can lead to ischemic stroke. So discontinue in female taking the OCPs and has migraine with aura. Management of migraine in pregnancy. Non-pharmacological therapy is rest, hydration, and heat. Then give acetaminophen. Antiemetics, for example, promethazine, codeine, caffeine, and butalbital. NSAIDs only in the second trimester, not third. NSAIDs, drugs, for example, naproxen, and opioids like oxycodone can be used in conjunction with acetaminophen, second trimester only. Then cervical insufficiency, painless cervical dilation in second trimester leading to loss of pregnancy. It is cervical insufficiency. What are types of abortion? Types of miscarriage or abortions are as follows. First one is missed miscarriage. There is no vaginal bleeding, closed cervical loss, no fetal cardiac activity, or empty sac. So basically it is a missed miscarriage in which the vaginal bleeding does not occur and cervical loss is still closed, but the fetal cardiac activity either is not occurring or the sac itself is empty. Then we have a threatened miscarriage in which there is vaginal bleeding, but cervical os is closed and fetal cardiac activity is present. Inevitable is when there is vaginal bleeding, dilated cervical os, product of conception may be seen or felt at or above the cervical os. Then there is incomplete miscarriage in which there is vaginal bleeding, dilated cervical os, some product of conception expelled and some remains. And complete miscarriage is vaginal bleeding, closed cervical os, product of conception completely expelled. So it means completely expelled, and incomplete means whatever start with I, inevitable, incomplete, in them cervix is dilated. So in incomplete and in inevitable, the cervix is dilated, while for the missed, threatened, and complete, the cervix is closed. Okay, and the eyes are open, others are closed. Yeah, the eyes are open. There's a mnemonic that whatever start with an I, so the eyes are open, others are closed. Then we have spontaneous abortion, common cause of bleeding at less than 20 weeks. Inevitable abortion presentation, there will be heavy vaginal bleeding, cramping, dilated cervix, non-viable intrauterine gestation in lower segment of uterus. So if the gestation happened over here, so that may be a chance of, that increases the chance of inevitable abortion or miscarriage. Common cause of first and second trimester bleeding is spontaneous abortion. Treatment: hemodynamic, if the woman is hemodynamically stable, give the expectant management and misoprostol. Hemodynamically unstable, give suction and curettage. Oxytocin is not effective as there are few oxytocin receptors in early pregnancy. Spontaneous abortion. Definition: it is a pregnancy loss less than 20 weeks. Risk factors are advanced maternal age, previous spontaneous abortion, and substance abuse. Treatment is expectant, medical induction, which is misoprostol, and suction curettage if infection or hemodynamic instability. Additional management is raw D immunoglobulin and pathology examination. Complication: hemorrhage, retained product of conception, septic abortion, uterine perforation, and intrauterine adhesion. Then this is suction and curettage. For example, this is pregnancy over here, and this is the uterus. Suction curette is inserted with a speculum opening the cervical os, and manual vacuum aspiration is done. Missed abortion is intrauterine pregnancy demise at less than 20 weeks. So missed abortion is that woman will never know that the abortion has happened because it will not bleed, but it is intrauterine pregnancy demise, the death of the fetus inside the uterus at less than 20 weeks of gestation. Risk factors are advanced maternal age due to increased risk of fetal chromosomal abnormality. Presentation is asymptomatic and decreased pregnancy symptoms, nausea, breast tenderness. Physical examination will show closed cervix and no bleeding. Ultrasound finding will show embryo without cardiac activity, empty gestational sac without fetal pole. Some early pregnancies can present without a fetal pole, hence viability is determined by serial ultrasound and serial beta HCG level. Repeat beta HCG level normally increase until the end of first trimester, but in case of missed abortion, decreasing levels are seen. What is complete abortion? Risk factors are cocaine, alcohol, and tobacco. Presentation are lower abdominal pain, heavy vaginal bleeding with passage of clots at less than 20 weeks gestation. Examination will show a closed cervix. Diagnosis is done by ultrasonography, empty uterus, normal adnexa. Beta HCG will be positive because it can take up to 6 weeks for the beta HCG to become undetectable. We are talking about complete abortion here. Then threatened abortion. Features are closed cervix, viable intrauterine gestation, vaginal bleeding, and subchorionic hematoma. So that is happening in the threatened abortion. Okay. There is cervix is closed. All the things that start with IE have open cervix. So threatened abortion which does not start with IE has closed cervix, viable intrauterine gestation, vaginal bleeding, and subchorionic hematoma. Then septic abortion. Management is with IV fluids, broad spectrum antibiotics, suction curettage. Hysterectomy is not indicated. It is indicated in the following cases: if we have pelvic abscess, if the patient does not improve after suction curettage and 48 hours of broad spectrum antibiotics. Note: misoprostol causes uterine contraction and expels the product of conception for spontaneous abortion. However, it is not used for septic abortion because of slow onset of action. Septic abortion. Risk factors are retained product of conception from elective abortion with non-sterile technique, missed or incomplete abortion, which is rare. Clinical presentation is fever, chills, and abdominal pain. Sanguinopurulent vaginal discharge, boggy tender uterus, and dilated cervix. Intravenous fluids, broad spectrum antibiotics, and suction curettage is the management plan. Then we have subchorionic hematoma. Subchorionic hematoma means like this. This is seen in the cases of threatened miscarriage, right? Subchorionic hematoma was present in threatened abortion. So here you can see that this is decidua capsularis, then we have the chorion, then amnion is over here. Here we have the yolk sac. This is the placenta, and this is subchorionic hematoma. Decidua vasalis, subchorionic hematoma, and maternal vessels. So uterine rupture, it occurs in the patient with a prior history of uterine surgery. Pain presentation is focal and intense, which is relieved by rupture. Diffuse pain after the rupture. Signs of imminent rupture are hyperventilation, agitation, tachycardia. Bleeding can be vaginal or intra-abdominal. Loss of fetal sensation is pathognomonic for the rupture. Okay, so for the rupture, the loss of fetal sensation is pathognomonic. There is no presenting fetal part. Diagnosis is fetal limbs palpable on the abdominal exam. Fetal heart racing are abnormal, for example, fetal tachycardia and recurrent decelerations. Disordered contractions occur because ruptured myometrial fibers cannot contract in unison, leading to progressively decreasing contraction amplitude. That is staircase sign on topodynamometry. So this is the staircase sign, like firstly level happening at level, this level, then this level, this level. Okay, and uterine contraction also decreased. Uterine rupture. Risk factors: Prior uterine surgery, for example, cesarean delivery and myomectomy, induction of labor or prolonged labor, congenital uterine anomalies and fetal macrosomia. The clinical presentation will show vaginal bleeding, intra-abdominal bleeding like hypotension and tachycardia, fetal heart decelerations, loss of fetal station, palpable fetal parts on abdominal examination, and loss of intrauterine pressure. Management with a laparotomy for the delivery and uterine repair. Then we have intrauterine fetal demise or stillbirth. This happens in cases of missed abortion. Fetal death at less than 20, more than 20 weeks. Okay, so that is intrauterine fetal demise. Otherwise, it would be missed abortion. If we go back to the missed abortion, complete abortion, where is missed abortion? This is. So if there is intrauterine demise of pregnancy less than 20 weeks of gestation, that is missed abortion. If it happens after 20 weeks of gestation, it is then termed intrauterine fetal demise. Okay, so it is also called stillbirth. Pathophysiology can be maternal, that is antiphospholipid antibody syndrome, and fetal-maternal hemorrhage. Fetus should undergo autopsy and karyotype genetic studies to see what the problem actually was. Placenta, check for thrombosis, abruption, infection, or other disease. Risk factors are fetal growth restriction, abnormal fetal karyotype, tobacco use, nulliparity, obesity, hypertension, diabetes mellitus. Up to half of the cases have no identifiable etiology. Presentation, decrease or absent fetal movement. Diagnosis, confirmed by absence of cardiac activity or on ultrasound. Inability to find fetal heart rate by Doppler sonography is not diagnostic as it can be due to fetal malpresentation or maternal obesity. Labor induction can be delayed until the patient is ready. However, delay for several weeks can lead to coagulopathy. Evaluation of fetal demise, fetal autopsy, gross and microscopic examination of placenta, membranes, and cord, karyotype genetic studies. Maternal causes can be Kelly-Hauer Betke test for the frontotemporal for the fetal-maternal hemorrhage, antiphospholipid antibodies, and coagulation studies. Crucial elements of intrauterine fetal demise evaluation include fetal autopsy, fetal karyotype, placental examination, and maternal laboratory testing for fetal-maternal hemorrhage and antiphospholipid antibody syndrome. However, often no etiology is found on intrauterine fetal demise. Then we have intrauterine fetal demise of stillbirth. Definition is fetal death more than 20 weeks. Diagnosis is absence of fetal cardiac activity on ultrasound. Management is 20 to 23 weeks by dilation and evacuation or vaginal delivery. More than 24 weeks to vaginal delivery. Complications, coagulopathy after several weeks of fetal retention. Caesarean delivery by the maternal choice of history of prior classical caesarean myomectomy. Evaluation of fetal demise or stillbirth. How do we do that? Fetal, we have done that table, right? It is the same table as this. So let's not do it again. Then we have antiphospholipid antibody syndrome. It is a hypercoagulable state. So the diagnosis is vascular thrombosis, transient ischemic attack, stroke, deep vein thrombosis, and or pregnancy complication, for example, recurrent miscarriage, plus more than one of the following antibodies like anti-cardiolipin antibody, lupus anticoagulant, and anti-beta-2 glycoprotein antibody. How do we manage that? Anticoagulant, for example, heparin and warfarin is given. Warfarin plus acetaminophen can prolong INR, and if increased INR means that PT is elevated and there is increased risk of bleeding. Systemic lupus erythematosus. So the symptomatology is malar rash, there will be pleuritis and pleural effusion, arthritis, livedo reticularis, which is cholesterol embolism. No, it is not cholesterol embolism. Maybe it is. Okay, then deep vein thrombosis. Then we have nephritis, nephritic and nephrotic syndrome, and pericarditis and pericardial effusion, seizures, psychosis, and cognitive dysfunction, oral ulcers. So there is a mnemonic that is SOAP, brain, MD. SOAP means serositis, oral ulcers, arthritis, and photosensitivity. Brain means blood, that is pancytopenia. Renal, nephritic, antibodies, ANA, Smith, dsDNA, immunological and neural, and malar and discoid rash will also be present. SLE nephritis in pregnancy, similar to preeclampsia, except there will be joint pain, malar rash, RBC cast on urinalysis, decreased complement levels, and increased ANA titers. Risk factor discontinuation of hydroxychloroquine, active disease prior to conception. SLE nephritis in pregnancy, Clinical presentation is edema, malar rash, arthritis, and hematuria. Lab findings will show nephritic range proteinuria, urinalysis with RBCs and WBC casts, decreased complement levels, and increased ANA titers. Diagnosis is done by renal biopsy. Obstetric complications are preterm birth, cesarean delivery, preeclampsia, fetal growth restriction, and fetal demise. Then we have preterm labor. So the risk factors for preterm labor include prior spontaneous preterm delivery, multiple gestation, short cervical length, cervical surgery, for example, cold knife conization, and cigarette use. Screening and prevention, cervical length measurement by transvaginal ultrasound, progesterone administration, and circulage placement. Cervical dilation in the setting of regular painful contraction at less than 37 weeks of gestation. The risk factors are history of preterm delivery, which is the strongest risk factor, short cervical length or on transvaginal ultrasound in second trimester, short cervix is identified at less than 2 cm without history of preterm labor or less than 2.5 cm with a history of preterm labor, history of cervical surgery, multiple gestation, advanced maternal age, and iron deficiency anemia. Transvaginal ultrasound measurement of cervical length in second trimester is the gold standard for further evaluation of preterm labor risk management. Given below in the table note, indomethacin is used for tocolysis. It can lead to fetal vasoconstriction, that is premature closure of ductus arteriosus, decreased renal perfusion, fetal oliguria, and oligohydramnios. Patients are given indomethacin for less than 48 hours. Oligohydramnios is associated with indomethacin use is reversible and can be corrected if the medication is discontinued. Then we have preterm labor management. If we have preterm labor on hand, we check for maternal instability, intrauterine infection, and fetal distress or demise. If yes, immediate delivery is recommended. If no, then if it is less than 32 weeks, it is very preterm. Antenatal corticosteroids, penicillin if group B streptococcus or unknown, tocolysis by indomethacin and magnesium sulfate. 32 to 34 weeks, which is moderate preterm, antenatal corticosteroids, penicillin if Guillain-Barré syndrome, not Guillain-Barré, if group B streptococcus infection or unknown, and tocolysis by nifedipine. And 34 to 37 weeks, late preterm, antenatal corticosteroids, penicillin if group B streptococcus or unknown. Okay. Preterm labor is regular contraction causing cervical changes at less than 37 weeks of gestation with intact membranes. Then there is another table about preterm labor. 34, 0 to 7 or 36, 6 by 7. Okay, so it is between 34 and 36 week, right? 34, 0 to 7 and 0 by 7. Okay, it is like 34 weeks and 0 days to 36 weeks and 6 out of 7 days. So between 34th and 37th week, okay, stop it. 34 and 36 week, betamethasone, which help with the fetal lung maturity, and penicillin if the group B streptococcus positive or unknown. From 32nd week to 33 weeks and 6 days, we give betamethasone, tocolytics, and penicillin if the group B streptococcus positive or unknown. For less than 32 weeks, betamethasone, tocolytics, magnesium sulfate for the cerebral palsy, and penicillin if group B streptococcus is positive or unknown. Then external cephalic inversion, it's not inversion, it is external cephalic version, ECV. So the procedure is manual rotation. It is done for the breech fetuses. Like we rotate the fetus manually, externally, like from maneuvering the abdomen. Manual rotation of the fetus to cephalic presentation decreases the cesarean delivery rate. Indications are breech or transverse presentation more than 37 weeks of gestation. Absolute contraindications are contraindications to vaginal delivery, prior classical cesarean delivery, prior extensive uterine myomectomy, and placenta previa. Complications include abruptio of placenta and intrauterine fetal demise. Relative contraindications are ruptured membranes, decreased amniotic fluid, and fetal prematurity, if not recommended during active labor due to its success at that time. It is not recommended during active labor because of low success at that time. We'll continue with abruptio of placenta in the next session. Until next time, Allah Hafiz, Fi Amanillah, and take care.